Bismillahirrahmanirrahim. Today we're planning to discuss and registers our second webinar about mastering the insulin pump therapy part 2. The discussions will include many parts, mainly indications of insulin pump, and secondly, initiations of pump therapy and how to do adjustment to the pump if needed. Okay. So the first slide started with indications for use of insulin pumps. The indications is widely. Um, Most important things because I believe that everybody or diabetic patients he need insulin pump to optimize his insulin and diabetes care, and we know that the pumps have very nice feedback or in improving his hemoglobin time and age, hemoglobin A1C, quality of life. Everything was being supported by many studies. So there no doubt the pump is very beneficial. But sometimes if you have some sort of lack of resources, you wanna just choose which patients need to be start an insulin pump first prior to give the insulin pump for them. So we said patients who have recurrent severe hypoglycemia. They deserve, of course, the pump therapy, and because it will reduce hypoglycemia and other patients with Down phenomenon. And we know that the pump will improve a lot the metabolic control of the patients. And sometimes we have control and metabolic control with complications and we have children sometimes with needle phobia, pregnancy is one of the strong indications in a type 1 to start a pump therapy, and patients with gastroparesis, athletics, patients who have flexibility or there is a fluctuations in their glucose profile and activities, or someone who have very hectic works or have a lot of trouble. So he needs something to take care of his glycemic profile in a nicely way, avoiding fluctuations of blood sugar stores, hypo or hypers. So he did nice work. And I like one statement, I just read it from the diabetes technology standard of care 2026. They said the decision to use the AIT system should be made based on the preference of the person or the patient or the caregiver, and also the availability of the resources to provide necessary training, access, and support them during their use of this insulin pumps. So whenever you have resources for insulin pump and you have motivated patients and family who can engage with you on this journey, you can start it. So initiations of insulin therapy, it need a lot of diabetes skills. We need the patients who know how to use a carb counting, how to tackle hyperglycemia, who is very known how to interfere with management of hyperglycemia, sick day rules, exercise and traveling, and you need thorough educations and training, viewing a pump availability to use a pump per se, how he can just use the reservoir, the setting, inserting oxygen, wearing with inserting insulin, vision set, wearing the pump, perform technical functions. He can know the role of each button on the pump. He can use it and he can understand along this journey of training will be done by clinical dietitians beside us and clinical diabetes educators, and it can be in a sessions according to the patient's need. Some patients can take 2 sessions, others can take many sessions till to make sure that he absorb each details in this pump therapy, which facilitate the work and the follow-up a lot from the start. If he knows the basics, if he can engage in each of the therapy or items, we will use it. And he need really it needs some sort of responsibility, and make sure that every patient was being candidate for this pump or raise his name that he's willing to work with healthcare provider, and the pump is available and he can take this pump supply at this pump supply will be at his hand. You cannot manage a patient to start his pump therapy. I'm not sure that he will supply the pump's needs or not. Okay, regarding insulin, filling the reservoir, changing set because he need to change the sets every 3 days. Okay, if it is available in the center for him, yes, that's good. Will be nice and very supporting things. Okay, so I like educations and the journey towards starting a book to be in a phases. The phase one, as I tell, this is continuous of introducing, meeting the dietitian, meeting the clinical educations, discussing with the physicians, and phase two will be for the starting pump. The journey of the starting pump, knowing the pump details like that. And the old theory when you start the pump, sometimes he said start the pump, filling the reservoirs and sleep with normal saline to let the patient train to the pump, train to handle the pump, where to put it, the syringe. But no more this theory was being used. We started seeing immediately for patients. We find him, he's capable to tackle this therapy and he was being ready to start. So no rush. You will take the patient and his family into thorough educations, and the educator and clinical dietitian and physicians will decide together when to start the pump. After starting the pump, phase two will be ongoing support from the doctors and healthcare professionals to monitor and see how, especially the few days, how he takes the pump. And last things we said, stage four, continuous educations. Every day we need to continue ourselves, update ourselves as a doctor regarding the new technology. And every time the patients come to you in the clinics with his schedules, follow up, you need to discuss with him the cause and pros, his concern, what's new for him, how he benefit, to answer all his questions and inquiry. Okay, and provide him every time with an online, either WhatsApp or telephones, to ask if he had any troubleshooting issue, and the warning letter to go to ER. At any times they have pump malfunctions which was not being resolved. I will discuss it later in details. Okay. طيب, the important thing is the goal of therapy. We need to be real, to give the patient realistic goals and expectations. He should know that the pump will improve his blood sugar glucose level. It will give him flexibility in his life. We will hopefully will avoiding the frequent hypoglycemia, and he can exercise now without a fear of hypoglycemia, other benefit of time management, improving hemoglobin A1C and so. But we should take or discuss with him an unrealistic goals which patients have. Like the pump will do all the DM care. You will put his hand off from the care and he will not, it will not be affected by any healthy behavior. No, he need to continue eating healthy food, slept well, doing his exercise, do his labs monitoring for complications, and the behavior of taking, they have this concept that whenever they want to eat, they can enter the carbs. That's it. No, still he will stuck to his daily requirements of carb countings and the healthy food we recommended for his life. Okay, and there is another misconception that he don't need to monitor blood sugars even when necessary. Yes, we said that the pump may not need to do some sort of checking the blood sugar, but sometimes the pump will ask you, enter the blood sugar value, especially if she did multiple corrections without unexpected multiple corrections or any sensor malfunction. So he should have his manual checking every time. Need to hold his manual checking with him and check blood sugars whenever is necessary. Okay. And as I said, there is misconception that you don't have to worry about the diabetes and don't need to carry diabetes supply anymore. No, you need to make sure that you have ready Novoben to be used at the time of if anything happened to the pump, and he need to take his glucagon with him, blood sugars, manual monitoring, everything to be standby checks just in case he need it. Okay. Uh, so if you want to shift the patients from MDI to insulin therapy, there is many variables will be there in the pictures. We need most of them. We need to make sure that the patients, and after you make sure that the patient is ready, you see his profile either by CGM or written data. The blood sugar is okay, he's stable. You don't have anything. Pictures of hypoglycemia. Hypoglycemia will affect my dose calculations. If he had down phenomena, his hemoglobin A1C, and of course, his age and weight will affect my insulin calculations. And we know that the insulin pump which you use it will be the short-acting one, which can be in a two-way, delivered as a basal as both, but giving the insulin every 5 minutes or hourly, the pharmacodynamics and the action of insulin is different from the long-acting one, which will be given once per day subcutaneously. Definitely, the absorptions will be different, and most likely you may suspect hypoglycemia if you give the same dose. So we'll take all these parameters. Every time we try to be as safe doctors, and we know that we don't want the patients to have hypoglycemia in the first few days while he is motivated. So we want to be safe in adjusting the insulin doses, and we said every time with the insulin bit, it's something individualized. Okay, but I will give you some scope for our framework for how to decide about the insulin dose. So, taking care of the basal, we have three methods on deciding how much basal we needed. Okay, the first method is to see the actual total daily dose the patients have. So let us take example for this girl. She's a 10 years old, no case of DM type 1 on MDI. Hemoglobin A1C is a 10. She have Down phenomena, no other hypoglycemia, with little bit hyper towards the evening. Her total daily dose 0.8 unit per kg per day. Her weight is 28 kg. She took 22 units as a total daily dose, divided by Lantus 9 units and Novorapid 4 units per meal. Okay, for this patient particularly, her age is 10, her weight is okay. We remember that she have high hemoglobin A1C is high, okay, with Down phenomenon. So the method of calculating the basal rate per hour, we took her actual total daily dose she took it. So we take average of 3 days total daily dose. For example, this she have 22 units. One day 22, one day 24, a third day 22. So we take the average of 3 days and we took it as total daily dose. So here the total daily average total daily, and remember every time in diabetes we talk about average. Okay, we don't give a fixed things because this is some sort of fluctuations. So if they took day 120, day 224, day 22, so her average will be 22 units per day. Every time the basal will be in a percentage. They said range 40 to 50% from total daily dose. Most of the doctor use 50% from a total daily dose. So using this method, the basal will be 11 units per day. Okay. The second method, we talk about weight method. This is the patients, we recalculate his total daily dose from the start. We said based on the weight, according to her age, the dose will be 0.8, 1 unit per kg per day. If we take 0.8, so it will be 22.4 unit per day. This is the total daily dose. Again, I will take 50%, so 50% will be 11.2 units. Till now, you can see how much similar, 11.2. The third method is to take her current basal rate. As far as there is no hypoglycemia, no other issue, we take the same basal rate, which is 9 units. Sometimes we reduce it by 20%, which is the preserve method. to reduce the total daily dose by 20%, and it will happen when? It will happen in a patients with recurrent hypoglycemia, small age group less than 6 years, and if hemoglobin A1C around less than 7 or 6.5, that means these patients have high risk to develop, most likely develop hypoglycemia, so we need to reduce the dose. So for my patients, you said we individualize the plan. A1C is 11, she's old, no hypoglycemia, so I will say take the same insulin dose. Then you need to take the average of all these three. Take average of actual dose, weight dose, beside the current dose, or reduce it if there is fear of hypo. So the calculation will be 11.29. So the dose, the total daily dose will be around 31.2 and will be around 31.2. If we take it, the average will be 10.4. And we want to divide it, we take it at 50% from it. Okay, so 11.29, 12, 31. And 31 average will be around 10.4. If we take the summary of it, will be around 0.43 unit per hour. We know that below 50% the basal will be, and we know the insulin pump we use it. We have a Medtronic. The increment will be 0.025. If we use T-Slim, the increment will be 0.05. So we don't have room for this 3. So we take for these patients, we divide it by 24 hours. The dose come to us 0.433. So we are making a dose between 0.45 or 0.425 as a total daily dose. Okay, this is we talk about the basal rate. Okay, the only tickling of basal rate is that sometimes we reduce it. Okay, we see next example for this slide talking about proportions. Again, the same concept of reducing the dose. In older children, we take basal 50-50 from the total daily dose. So as we said, this will be our basal. But if we are talking about a small age group, we need to take 30-35% of the total daily dose. That means we reduce it more by 20%. This is the risk of hypo. We discussed it, risk of hypo, small age group. So the basal will be around 0.35. You see, instead of 0.45, will be 0.35. And this is this very preservative method. Most of the time, the doctor use it. And if sometimes we need to take other solutions. For example, and patients, I calculate his dose like the patients. I took example of it, and I'm planning to make the basal 0.45 unit per hour. Okay. Sometimes I create another basal for the patients. I give him because he will start manual for the first 3 days. So the first 3 days, I will give the patients another basal. I take same, name it as basal 2. And I start basal 2 with this small dose. And I inform the patients, when you go home, just test what happened to the blood sugar. And then if you develop hypoglycemia or something towards low, just shift to basal 2 till you came to the hospital or discuss it with the care provider. So this is a safe method. Every time took any ways that let your patients be safe. Okay. And as I said, the basal can be divided into segments during the day. For this patient specifically, she have Down phenomenon. That means we need to increase the dose 2 hours before sleep times for the patients with Down phenomenon. Okay, for here, just a sketch for tell you that the basal can be divided into segments. So if we take a segment of night from 12 to 6, I will give her the high dose, 0.45 unit per hour to take a Down phenomena. And during daytimes, I will let her go with a little bit smaller dose. And during evening time, I will give the biggest dose. So here I have 3 basal to be taken during the day. As here, example, we can create 3 basal. Now we are talking about the 3 days she will use the manual mode. Okay. And after 3 days, she will start on smart. Once you start the smart, no need for this second because the smart card mode, it will do the basal as automatized from the algorithm created by the pump. Okay, but this 3 days is very beneficial because the pumps will study the patient's behavior, the blood sugar requirements, and it will create the algorithm. Sometimes we tell our patients we need these days to be a calm days, no too much snacking, no special occasions. And patient, if he will sick, we will not start the pump at that days because the pump will study the program. And now we are talking about basal. For simple questions, if a patient took his basal as a routine daily in the morning, so at the time when they are going to start the pump, he will skip a morning dose and come to the hospital and do the manual mode and do your calculations. Another scenario, if the patient used to take it at night, like example, most of the patients use it to 7 to 8 p.m. You will ask the patient to skip this dose and to do monitor the blood sugars Q4 hourly and add corrections because he will be without the basal blood sugar may raise. So he need Q4 hourly to do corrections. Sometimes the patient took his lab test or his glargine and came to you in the morning telling him, I took the dose last night by mistake. Okay. At some time, still, yani, we can weigh things out. We have some way to give basal zero. Give him one basal zero till after 24 hours. You give him two basal, one basal zero, other one is the active one. So we let him continue without a basal for the coming 24 hours. After that, he will start his program of basal. يعني the patients will be very motivated at the time of starting the pump. So you will do your best to be with the same level with them, but in a safely way. Okay, this is we talk now about when to start the basal, how to do about the MDI basal, he took it or either he skip it, and how to adjust the dose of a basal. Okay, moving to the ICR for the cup. The ICR is very easy things. We took the same concept of before. If a patient is using an ICR before and he do good cup countings and everything is going well, we are trusting the ICR he does by MDI. So we will start the same ICR. Second, we can estimate the ICR regarding how much he took per day carbs. For example, he said divided by a total daily dose. For example, he said I took around 200 grams per day. For 200 grams per day, and I took the same 50%. طبعا percentage you took it for the carb from the total daily dose, we take again 50 to 60%. So if his total daily dose is 22, we take 11. So 200 over 11 will be 18 units. And we have one patient who is not willing to learn her carbs a lot, but she know what she eat. She have little bit to some extent fixed meal. She took like in the morning every time cornflakes, cup of milk, and in the evening, in the afternoon or the lunchtime, she used 2 slices of bread with some sort of meat. So we go and discuss with the clinical dietitians and with her her food record, she bring food record, and we estimate what she took for breakfast, how many carbs, what she took for lunch, and we just see her glycemic profile during breakfast, lunch, and dinner. And we said it was being very optimal. She don't have any excursions above meal times. So simply, we tell her how much to eat. For example, she eat 90 grams, and she eat how many units of insulin. She said, for the 90 gram, I eat around 6 units. So her ICR will be 15, we estimated. So you can do any maneuver to make sure that you go around the right number. Or you can do it by the other maneuver, which is the rule. 400 to 500 rule. So here, every time we use 450 rule divided by total daily dose to create an ICR. Or in young children, you use 350 rules. So you can imagine estimated daily carb or by our rule of 450, it will be around 18 to 20. So we are some extent near the number to each. Okay. And this is how we can create many carbs segments during the day. You can make special segment for breakfast, a special segment for the lunch, other one for the snack in a time frame. Okay, for this patient, he have two segments. His carb ratio is 3. We see 3 in that lesson. Okay, ISF the same matter. If he have ISF before, which is very good, we said correcting, no hyperglycemia, once he correct, we'll use the same. Or we do our standards. 1,800 over the total daily dose if we're talking about milligram, or 100 over the total daily dose if we're talking millimole per liters. There is some sort of adjustment, sometimes adjust upward, 200 over the total daily dose for the one who have insulin sensitive, or 1,500 for those who have more insulin resistance, so we need more doses. And this is how you can see ISF. Okay, and sometimes this is regarding our recommendation for the blood sugar, how much it will be, and for the active insulin times. The active insulin times with the pump came with the Medtronic as 3 hours, 2.5 hours, or 2 hours. So you will adjust it according to the patient needs. Sometimes you need the pump to give you more corrections. You want to tell how my insulin now is finished. I need another correction. So you will choose 2 hours and the reserve. If you want to use 3 hours, that means it will not correct easily because she thinks there is insulin on board and she will delay correcting. So bolus wizard is a old story used with a 670G, the previous pump, and we learn from it the issue of too many issues. The first thing that the meal dose depending on about the carb you take, the prior blood sugars, and and sometimes even the row of a curve where the blood sugar is going up or down or static. Okay, so I used to write this for my patients. In a MDI, I tell him calculate the food. You take how many grams divided by ICR, it will give you any correction. You take the target, the current blood sugars minus the target divided by ICF. Give you this. You will combine these two doses to give the food meal. The things which is different from pump because it will subtract active insulin times from this dose, from the dose of corrections, not from the dose of the meal. From the dose of corrections, it will subtract the active insulin times and give you the dose accordingly. It will not subtract from the carbs for the meal because this carbs designed for this 13 grams of carbohydrate. Okay, we call it at that time bolus wizard. In Arabic they call it ساحر الجرعات في التعريف بتاع البامب القديم. Okay, فهنا very clear. She will subtract the insulin on board, and this is the beauty of the pump. طيب, second part, how we adjust the insulin therapy after starting the insulin pump. Because here, first we finish, we do the basal, we do ICR, we do ISF, and then we ask the patients to go 3 days on manual mode. And when he came onto 4, we shift the automatic or safety mode. Okay, smart card mode. In a pump, what you need, what is the things which you can change it while you are following the patient on pump therapy. Okay, we are now having Medtronics 780Gs and a control IQ T-Slim. Omnipod, it was been available in other hospitals, and sometimes have 2 patients following us as well. So if we talk about Medtronic, from the start, you can adjust the targets. You have targets of 100, 110, 120. So 100 if you need more diet control, 120 is the less one. Okay, in a control T-Slim, as we discussed last time, it is a strict range. So this range is widely, you cannot touch it. Okay. And you can shift the patients to 10 basal, which is basal 150 during exercise. And she will correct. And another things you can make it an ICR. You can add an ICR, change an ICR from the meals, okay? So changing an ICR, you can do it as if it cannot. So my mean, active insulin times, well, ICR, and what I said are targets. Let's see what is there. And if a patient's in Medtronic 780G smart card, why you need to change the basal? The basal will be changed automatically as we discussed before, according to the algorithm there, and it will do fine tuning the blood sugars up and down. But why we need to look every time during follow-up or from now into the basal? Because if a patients go out from the smart card mode, that's to say she have malfunctions due to any problem like there is problem in the sensor, problem in the pump, anything, it will go back to manual mode. So if it go back to manual mode, it will turn again to the basal where you set it in the pump, either first time or either during changing the pump. So this shift is the things which let us need to correct. If you use the old programs, here the 670G, you can change the basal every time because it is acceptable. Okay, they have made any basal you have before. We make basal for daily routine, basal 1, basal 2 for Ramadan times, basal 3 for exercise, basal 4 for, you can create many basal as much as you can. Is in the old mode, okay? So if you would test the basal in the old mode, we can make a segment for the basal. The segment divided by, you can make segment overnight, segment for early morning, midday, and late afternoon. You take in a segment way, okay? And or you took the segment where there is a problem. So patient have hypoglycemia in the morning, you will take this segment and test it first for the basal. There is preconditional for testing the basal. This time, he will not eat, of course, or bolusing anything carbs. And we can tell him simply, either we can do it overnight, it's a very easy thing because already the patient slept from 8 or 10 to 6. So this is a great segment to test it. Make sure he did not eat immediately before sleep. And during daytime, we ask him to skip a meal. It is a very difficult, tough issue, but sometimes we do. Some patients may respond to that testing. And then, if no, we just seek at times where there is no policies. And before we go to the logbook and just search for a time when the patient did not enter carb or do correction and see what happened to the blood sugars, what happened to the curve of blood sugars going up or going down in hypoglycemia. We may find the segment without carb and judge on it and adjust the insulin dose. Okay, so the conditional of a basal adjustment, we need the blood sugars to be within target at that before starting the test, 91 to 145 millimoles. And we check the blood sugars hourly. We can use the sensors, okay? And we will see. We accept the blood sugars to teeny fluctuated, but the fluctuations should not exceed 2 millimole. We can set around 36 or 40 grams per deciliter through the night only. So if you slept 120, we'll accept 160, no more, plus or minus. So if you find any fluctuations more than that level towards up and down, that means you need to adjust the basal. Well, basal adjustment need to be, we need to check it hourly. If you find it at 6, so you will go by 5 a.m. and change the basal by very teeny change, either to increase it by 0.025 to 0.05 if it needed nearly, or the same number up and down. Okay, so if for example, severe hypoglycemia, you can reduce by 0.05. Okay, for up and down search and make it 1 to 2 hours before the problems happen. Okay, type. As I said, hybrid loop closed system, you need to see because it may go out from the smart gut at any time. So you look evidence of auto basal corrections. You see, every time she exceeds the basal, then she gives microbolus. It is either the basal is low or weak ICR for the previous meal was being used. And sometimes you can see sometimes there is suspect basal. For a long time, there is no basal. That means the basal leukocyte is high or you give too tight ICR. Okay, and we have a special circumstances for sick day management. Sometimes you set in an old pump, there's automatic pump, you need to increase by 20 to 40%. Sometimes we make a special يعني second basal for the sick day rule. So we recommend it to spend maybe 4 hours, okay? But for the, most of the time for the smart card advanced they just allow around 2 hours per week, or sometimes 2 hours. They said per 2 weeks is the only time advisable because the single pump will help you every time. So why you need to suspend it or stop it or go to the white mode or close it? It help you. We don't have risk of hypoglycemia to stop by pump. Okay, and you need to tell the patient and discuss with him clearly stopping the pump therapy whenever the blood sugar sustain high, not corrected, or you have positive ketones, we need to remove a pump, or any element of pump malfunctions. And to start immediately correct by pen, novo pen, short acting, and change your reservoir, change your insulin set. If the problem was not solving, in a few hours, you need to go to the nearby hospital to solve the issue. So this is for the basal. Policies adjustment for the carb, that means changing the ICR. Ask the patients to eat low-fat meals, so we don't need a late absorption issue, and try to make no snacks in between the meal he take it, and let him check his blood sugars before the meal and check it hourly till he reach 4 hours. Then we will see our programs, what happened. We expect that the blood sugar will be raised slightly and go down to the basal after finishing this 2 to 3 hours. Okay, so we have a target of fluctuations again about 2 millimole, which considered as normal. That means around 40 grams. So if he start to eat at 200 blood sugar, we expect it to be maybe 140 is okay, acceptable for us. But if it shoot down or in the hypoglycemia, you need to change the ICR. ICR can be changed only 10 to 20%, which is equivalent to 1 to 2 grams for a specific meal. If we said he have hypoglycemia, post the meal he took ISR of 10, we can make ISR 8. That's it. But before changing, make sure that he just policies at the time when he announced the carbs before he eat, and he have good carb counting techniques. Just review with him, and again, if he adherent to the bolus whether in the other pumps or no, where he need to enter the blood sugars value. Checking every time, repeat with him carb counting, and make sure that when you decide about the bolus, you have the general recommendations that small children will be around 20, school age 15, and the adolescent may be more than 10, you find 5 or so. So if you calculate carbs for a patient who is adolescent 30, this most likely you calculate it wrongly. And ISF, as I said, ISF, the new machine will not change your ISF, but in the old one, you need to change it. And for the ISF, again, the same story, but we need at that time to select a segment where there is hyperglycemia, blood sugar is more than 80 millimole, and you give insulin according to this ISF, and then we will see if the blood sugar at that segment normalized. It's okay, we'll continue the same ISF. No, it was being surged up. If it is surging up, we will improve our ICR and reduce it by 5. Instead of taking ICR 70, we'll take 65, so we will take more insulin dose. And the versa. If you have hypoglycemia, you will increase it by 5. Okay? So this will be 5 equivalent to adjustment around 10 to 20%. Okay, so this is the corrections, and every time make sure that the patients will eat healthy meal with the desired carbs for his age. And in our system, I found one icons for power charge for the pump. I didn't use it, but I think next time, inshallah, I will utilize it because it will be easier for us to document what we have. Okay, so take home message: insulin pump initiation is the only beginning. Individualized therapy. Start with conservative average doses, adjust systemically using glucose data, prioritize safety by preventing hypoglycemia, and empower motivate the patients and the family through continuous educations. Okay, and this is some sort of our activity. We did it in one of the schools for introducing school to the introducing diabetes and health lifestyle to the student in one of the primary school in Riyadh. Thank you. I hope my discussions was being clear, and inshallah next time we will go to discuss the third part of our mastering insulin pump therapy. Thank you.